Hello everyone, I welcome you all to the INICET November 2025 recall done by MDS CONQUER. When I inquired with most of my students who have given INICET, they told me that yes, the paper revolved around concepts which were taught in the class, but definitely when we compare to the NEET module, INICET module was somewhat moderate or moderate to difficult. Right? So after speaking to many of them and after conducting a few discussion sessions on the paper and collecting the questions, we are coming up with the recalls. The recalls that we are doing are mainly for two purposes. Okay. First purpose is to let you all know what are the most important topics in each and every subject around which we can expect that questions are going to revolve. This is the main criteria. Right? For people who have not given INICET also, I feel your focus should be definitely revolving around the topics from which maximum number of questions have been asked in this November 2025 INICET. That's the first thing. And the second thing is to get a clear understanding and clarification of certain topics and probably digging a little bit more into depth about certain topics and knowing in detail what is the correct answer for each and every question that they have asked. Okay, these are our two main important criteria. What will be why we are discussing INICET recalls, right? And one more important thing is there can be ambiguity in the question because these are all collected from the students, and there can be ambiguity in the options as well. So if you guys know a better framing of the question, or if you guys know if these were not the options, or if you're very clear with the other options in a particular question, I request you all to kindly leave a comment below so that we can modify the question and discuss in later upcoming recalls as well. Right? So with no further delay, let us start with our first part of INICET recall. Welcome everyone. Right? The questions have been picked up quite randomly. So we'll just go and see into each and every question, analyze the options and come to the correct answer. Right? The first question, 25-year-old woman, okay, presents with the gingival tissue that appear red, shiny, peeling. Okay. Now this peeling, I don't know whether they have given desquamative gingivitis in the question or not, but definitely when you have peeling of the gingiva, the first thing that comes to our mind is definitely desquamative gingivitis. Okay. Now there's a further extension to the question. Which of the following conditions should be considered in the differential diagnosis? Okay. So desquamative gingivitis alone usually does not exist as a lesion. It is a part of certain autoimmune skin disorders. Already we had covered in the skin class, right, in OPOM. What did I tell you? If you see, before I go to the options, if you see this is the screenshot of the class, okay, I told you, yes, when you get the concept of desquamative gingivitis, usually it is present associated with certain autoimmune skin disorders like lichen planus, mucous membrane pemphigoid and pemphigus vulgaris. Okay, one second. Yes, lichen planus, mucous membrane pemphigoid and pemphigus vulgaris. Okay, these are the three most important conditions in which we see in the gingiva very thin friable gingiva which peels off quite easily. Okay, suggestive of desquamative gingivitis. Now let us have a look at the options. Okay, so definitely it's not erythroplakia. Right, you do not have any peeling of gingiva and erythroplakia, not epidermolysis bullosa, it is not associated with desquamative gingivitis. The other two options, yes, oral lichen planus and mucous membrane pemphigoid, yes, these two are definitely associated with desquamative gingivitis. Now among this, which do you think is a better option? Okay, oral lichen planus presentation is very characteristic on the buccal mucosa. Okay, very few ulcerative or erosive forms, very few forms appear on the gingiva. Okay, the propensity of buccal mucosa to gingiva, if you see, gingiva is very less for an OLP to occur. Okay, and that too, if at all it occurs, most commonly I told you, OLP of gingiva is called as, this is a very commonly given MCQ. Oral lichen planus of gingiva is called as desquamative gingivitis. But then when we look at cicatricial pemphigoid, very clinically characteristical appearance is that of certain bullae on the gingiva which rupture and give you that desquamative gingivitis appearance. So if you ask me, yes, both of them are correct options, but if you ask me the better option among them, I will definitely go with mucous membrane pemphigoid then oral lichen planus. So your option is B is greater than A. Always in a pemphigoid, the amount of desquamative gingivitis lesions, the the incidence of those lesions are very higher compared to oral lichen planus. Okay, so if you see here also, this is taken from Schaefer's. This is a screenshot that I have taken from Schaefer's. So if you see here, most important dermatosis, by dermatosis I mean skin disorders, who present with oral findings, okay, as desquamative gingivitis are, first one is your benign mucous membrane pemphigoid, okay, or cicatricial pemphigoid, then comes your pemphigus, last is lichen planus. Other diseases like pemphigus vulgaris, epidermolysis bullosa, SLE have very less involvement. Okay, so this is very important, all your dermatosis associated with gingival lesions. I think this is a very clear-cut question. Most of you have given a correct answer for this, have gone for pemphigoid, mucous membrane pemphigoid. Let us go to the second question, very easy question, very direct question. Okay, what is the most accurate radiographic method for detecting proximal caries of primary molars? Okay, so everybody knows for interproximal caries the best radiograph to detect is bite wing, right? Your answer is bite wing. If I frame this question and if I ask you best digital method, if I ask you best digital method for interproximal caries, what will be your answer? Yes, digital fiber optic transillumination. Okay, if it is digital method, it is digital fiber optic transillumination. If it is a conventional method, the best radiograph to take is your bite wing radiograph, right? Very clearly covered. Positive angulation is around +7 to +10 degrees. Everybody knows this vertical angulation, right? And it is directed at the interproximal region. Very clear. Already we have discussed this multiple times. Very simple question. Easily you can score the marks in this. Third question. Which type of dental radiograph is shown in the image? As far as I have discussed with my students, they told me that they had something like a reconstructed panoramic image like this, okay, and multiple multiplanar section images like this, okay. So where do you see this, right? While discussing the class in CBCT, I told you the initial image that we take in order to see, go further for the sectioning in order to analyze everything is a reconstructed panogram. Reconstructed pan that appears like this, it appears like OPG. From this you do a multiplanar reformation and then you analyze each and every section individually depending on what the diagnostician wants. Okay, so they have given you these options and they are asking you what it is. Is it an OPG, it is an occlusal radiograph, CBCT reconstructed image or intraoral digital image? It is very clear that from the set of pictures that definitely it is a CBCT reconstructed panoramic image, right? So this is quite clear, no ambiguity in this question. If there is any change in the options, do let me know, but from whatever I have got, very clear cut, this is a CBCT reconstructed panoramic image. Okay, let's go into the next question. Patient presents with a cystic lesion in the anterior palatal region. So cyst, anterior palate, definitely what comes into our mind? Definitely, yes, nasopalatine ductus. That is the first thing that will go into the brain, strike you there. Okay, which of the following clinical signs are commonly associated? So they told me, ma'am, we got a clinical question of nasopalatine ductus and they gave multiple statements. It was a multiple statement question. Okay, so I hope these are the 4 statements that they have given. Midline swelling in the anterior palate, bluish elevation of the incisive papilla, non-vital maxillary central incisors, unpleasant or salty taste sensation. Okay, these are the 4, and they have given which of the following are correct, like multiple options have been given. So definitely, is it a midline swelling in the anterior palate? Yes, I told you it is a midline swelling in the anterior palate. If you check, see, this is from your smart videos of OPOM. This is your developmental disorders. If you see very clearly, I explained in the developmental cysts where there is persistence of the epithelial remnants in between your both maxillary central incisors, you have a heart-shaped radiolucency similar to this, okay, and the teeth are vital. Already very clearly I have explained this, okay. This is called as Nasopalatine duct cysts, okay. So, same question, yes, it has a midline swelling in the anterior palate. There is a bluish elevation of the incisive papilla. If you see here, definitely there will be some elevation of the incisive papilla because of the cystic contents pressing on the cortical plates, definitely causing some amount of elevation. Next, this is also correct. Is it associated with non-vital maxillary central incisors? This is absolutely wrong statement because in the nasopalatine duct cyst, the teeth are vital. This is very, very important for us to diagnose it from a differential diagnosis of radicular cyst, okay. Yes, if tooth are non-vital, definitely your chances of the diagnosis being as a radicular cyst increases, okay. So, this is not correct. Unpleasant or salty sensation, unpleasant or salty taste sensation, when do we usually ask, do you have that salty sensation in your mouth? Usually because of pus, secondary to pus. Okay, and again if I am talking about secondary to pus, definitely it has to be something to do with non-vital teeth and radicular cyst. So, I think this also should be wrong. So, only midline swelling in the anterior palate associated with elevation of the incisive papilla. So, I think option 1 and 2 are your correct options. Okay, option 3 and 4 are more commonly going towards your radicular cyst, right? Yes. So, again the same question we have given in our, this is taken from your QB question bank in your same thing. Soft, fluctuant, tender swelling in the hard palate with vital anterior teeth. There is radiolucency between the roots of the maxillary central incisors. So, you have practiced this many times. Okay. So, this question is quite easy to answer. Next question. Okay, a very ambiguous question this is, because we don't know what is the radiograph that they have given. Okay, so let me read this. Based on the radiographic appearance of the jaw lesion, identify the most likely diagnosis. Okay, so my students came and told me that, ma'am, they have given a small section of OPG, something like this only. Okay, and then they gave some amount of radio opacity in the near the molar region. There is a surrounding radiolucency like this. Okay, and then they are asking you what is the diagnosis. So, let us look at the options: osteoid osteoma, cemento-ossifying fibroma, osteomyelitis of the jaw, osteosarcoma. I am assuming that this is the this is how the radiograph is given. Based on that, I am giving you the diagnosis. Okay, if this is the radiolucency where you have a small radio opacity surrounded by radiolucency, yes, this appears like bullseye. I have told you which is the long bone tumor in which you have bullseye appearance. Previously also in some INICET it was asked, okay. So, I told you in bullseye, if you see, the answer is yes, correct, it is osteoid osteoma. Okay. So, usually these are less than 1 to 1.5 centimeter swellings. Okay. They have a central nidus which is radio opaque. Around that a small radiolucency is there, usually seen in the posterior mandible. They are seen in long bones, but if at all they are present in the jaw, posterior mandible is the common site of location. Okay. What about cemento-ossifying fibroma? Okay, if this, see, so this is the same picture that I have taken from the smart video. Very clearly I have explained. If you can see here also in the posterior aspect of the jaw, if you can see central nidus surrounded by a radiolucency, and this is the axial view. Here also you can see that bullseye appearance. Okay, yes, if the same picture showed a massive swelling, okay, if the swelling was massive, If the swelling had some external effects, by external effects I mean any displacement of the teeth, okay, any resorption of the root, or any cortical swelling, okay. So if you can see here, definitely there is a cortical swelling both on the buccal as well as the bicortical swelling is there. Buccal and lingual aspect, you can see a bicortical swelling, okay. So if this is there, okay, and then if there is a mixed lesion, okay, somewhat radiolucent and radioopaque as seen here, okay, then your diagnosis of cemento-ossifying fibroma will be correct, right. This is a huge swelling, definitely more than 2 to 2.5 centimeter, huge swelling. But what we saw in the radiograph that was given to us is a small swelling, okay. If you can see, it's a very small swelling. So definitely it is not cemento-ossifying fibroma. What about osteomyelitis? Osteomyelitis, I told you, it starts with fuzzing of the trabeculae and then you have moth-eaten appearance. Except for caries where you have a onion peel appearance, okay. This again they will give you a occlusal radiograph to see this. So this is also not correct. And last one, osteosarcoma, you have a sun ray appearance, you have spicules which are radiating from the periosteum because of the periosteal reaction. So osteosarcoma is also not correct. So definitely when we are talking about bullseye, your answer should go towards osteoid osteoma. Now because we are talking about bullseye, can you tell me like what other lesions I have told you where you see bullseye appearance? Very, very important, okay. So if I talk about clinically I see in erythema multiforme, bullseye appearance, okay. If I talk about radiograph, very important, if I talk about radiographic features, I see it in lingually impacted teeth, okay, lingually impacted teeth. Then I see it in osteoid osteoma, just now we saw. Then I see it in dilaceration, okay, lingually impacted teeth, osteoid osteoma and dilaceration. These are very, very important. And one more is phlebolith, soft tissue calcification, okay. This is a very, very, very important table, okay. So where all you see bullseye appearance, clinical it's erythema multiforme, radiograph lingually impacted teeth, osteoid osteoma, dilaceration and phlebolith, okay, very, very important. Let's go to the next question. 63-year-old man reports with jaw pain and swelling. So you have jaw pain and swelling. There are multiple well-defined punched out lesions in the skull, okay, also in the bones and jaw. When we think about punched out, definitely first thing that will come into your mind is multiple myeloma, because this is that many number of times that in our daily discussions, in our question banks, in our grand exams, everything we discussed about these multiple punched out radiolucencies. Along with that, they gave another additive feature that they are having Bence-Jones proteins in the urine, okay. So definitely very easy to go towards option, that is multiple myeloma, right. So this is our daily discussion board that we discussed, right. We have already discussed multiple punched out radiolucencies, and in the recent and recall also, just before your INICET, I had discussed the previous paper, INICET and NEET 2025, okay. So here also in gel electrophoresis they have given a spike, M spike, so that also I have discussed, okay. So wherever you see M spike, okay, in the electrophoresis, when you see punched out radiolucencies, right, then definitely your answer should go towards multiple myeloma. Can anybody tell me what is that punched out radiolucent skull called as? It is given a specific name for multiple myeloma. Yes, it's correct. It's called as a raindrop skull. Okay, so apart from multiple myeloma, our point is to discuss where else do we see punched out radiolucencies. We see it in eosinophilic granuloma, and the second one we also see it in Hand-Schuller-Christian disease. Okay, so in eosinophilic granuloma they are irregular. Okay, and in raindrop skull they are regular. Okay, Hand-Schuller-Christian disease, you have associated exophthalmos also, and diabetes insipidus. Okay, so these are very, very important when we are talking about multiple punched out radiolucencies in the skull. Next one. A 12-year-old patient presents with multiple jaw radiolucencies. Again, we have multiple radiolucencies here. Clinical examination shows bifid ribs. Okay, we are going towards a syndrome. Pits on palms and soles, okay, and calcification of falx cerebri. How many times did we discuss this question? Okay, this is one of the most commonly asked. Yes, all of you are correct. Nevoid basal cell carcinoma syndrome or Gorlin-Goltz syndrome, which is a commonly associated question from the odontogenics, which is invariably asked, that it is very, very important both for INICET as well as NEET. Okay, so they are asking which of the following is the most common syndrome associated with it. We have noticed that in INICET many questions were asked with respect to syndromes. So syndromes are very, very important, be it part of genetics or be it part of OPOF. Syndromes were focused a lot on INICET. Okay, so when we talk about this, the answer is yes, nevoid basal cell carcinoma syndrome or Gorlin-Goltz syndrome. What are these multiple jaw radiolucencies he is talking about? Yes, these are either multiple OKCs or multiple dentigenesis that you see associated with nevoid basal cell carcinoma syndrome. So yes, we have just before the class, we have discussed the same thing I gave you. I gave you a case presentation on our WhatsApp discussion. You can see multiple OKCs here. If you can see in the center, you can see a center line. Okay, this is calcification of falx cerebri. Okay. Yes, then you have your palmar plantar pits. Okay, along with this you also have bifid ribs. This is indicating that bifid ribs in the chest. So all this is associated with Gorlin-Goltz syndrome or nevoid basal cell carcinoma syndrome. It's a very, very important question. Cannot afford to not know it. Okay. Another question related to a syndrome. In Pierre Robin sequence, they are asking which is not part of the classic defining features or classic defining criteria. Okay, small jaw or micrognathia or retinognathia, downward or posterior displacement of tongue, which is called as glossoptosis, clefting of the soft or hard palate, difficulty in breathing due to airway obstruction. Okay, again we have discussed in our classes Pierre Robin syndrome. I told you it's a triad of micrognathia, micro or retrognathia. Okay, associated with glossoptosis and a palate cleft. Okay, either a hard or a soft palate cleft. Okay, all because of this, because of the downward pressing of the tongue, there is airway obstruction. So this is not, these are all primary classic defining criteria. This is a consequence or a secondary criteria. Okay, where because of the primary conditions that are causing this syndrome, there is a airway obstruction. So if we see here the answer, yes, microretrognathia is there, glossoptosis is there is clefting of palate, but difficulty in breathing due to airway obstruction is a consequence of Pierre Robin syndrome, but as such it is not a part of the syndrome. The answer is D. Clear? Everything, all the four are part of the syndrome, but yes, which are primary, which are secondary, we need to clearly delineate and then come to the answer. Next one is a very straightforward question. I have noticed that a few of my students came to me and told me, ma'am, it was like sitting in your class, like when we were answering questions related to oral path and oral medicine, it was like you are coming and teaching us the class because everything that you have taught in the class has come as a question. Okay, so it's like people who have attended the classes here in Mdsconquer, you will know that multiple times we have stressed a lot about all the important syndromes and all the important conditions which are commonly asked in NEET and INICET, and also we have discussed a lot about the framing of the question, or we have discussed different variations of how the question can be asked, like many clinical presentations. Like if you see the grand exam also that you have written in OPOM, we have given you multiple questions in the format of case history presentation so that you are acquainted to, different format of asking the question. So like that also you were exposed to a lot number of questions. So it was easy for you all to answer. So similar question came in our INICET also, which we had asked in our grant test, similar to that. Sparse scalp hair, malformed teeth, inability to sweat properly, nail abnormalities. So yes, alopecia, scalp hair, okay, malformed teeth, pet teeth that we have already discussed, right? Inability to sweat, hypohidrosis, right? And dystrophic nails. So all are ectodermal abnormalities. So yes, when you have multiple ectodermal abnormalities, teeth, skin, hair, sweat glands, yes, very good. The answer is ectodermal dysplasia. Already I have discussed, okay, we have, see here, alopecia, peck-shaped teeth, missing teeth, congenitally missing teeth, hydrosis, hypohidrosis, okay, anhidrosis we have already discussed. Everything comes under hypohidrotic ectodermal dysplasia. So the answer is A. Very, very simple, very straightforward questions. There is no ambiguity in the options also. You people told me that it was easy to answer, very straightforward. Next one. Which of the following conditions commonly presents with frequent recurring oral ulcers? Okay. So when we were discussing in the class also, I told you multiple oral ulcers, right? We have syndromes we discussed. We have Behcet's, right? We have Reiter's. Then we have PAFA syndrome. Then we have magic syndrome. All this we have discussed when we are discussing about multiple ulcers. So if you see, okay, if we consider that you do not know where multiple ulcers are present also, if you see the options, Behcet's, you know definitely multiple ulcers are there. What about Peutz Jeghers, internal malignancies, right? And you have melanotic macules, melanocytic macules. So this is not the answer, right? Right. Trichocolin, again, not associated with ulcers. Gorlin syndrome, not associated with ulcers. So the answer is Behcet syndrome. Here again in one of the question you got magic syndrome is a variant of which of the following? Yes, in the conditions we have discussed, both magic syndrome as well as Behcet's are associated with recurring ulcers. So very, very easy to come to the diagnosis of that. So we are done with part 1 recall. I'll meet you all with the part 2 recall. Happy studying. If you guys have any doubts with regarding to the framing of the question or any changes in the multiple options that I have provided here, you can always let us know. Keep following us for part 2. Thank you so much.